Top Med Talk. Hi, I'm Monty, Mythen, Editor-in-Chief of Top Med Talk, coming to you live from Anaesthesiology 2018, the annual Congress of the American Society of Anaesthesiology. We're in San Francisco, in California, in the United States of America. You'll find us this year on the Smith's Medical booth, that's booth 1519 in the trade exhibition. We also have an education booth where you'll find both the Top Med Talk team and evidence-based perioperative medicine, mpom.com. You'll also find the team from UCL promoting the master's program there and the MOOC, the Massive Open Online Course. I'm joined by familiar voices, Professor Mike Grocott, colleague from Southampton, the United States of America.
Hi, Monty.
And our lead anchor in the United States of America, Desiree Chappell from Louisville, Kentucky. Desiree, how are you?
I'm great, Monty. How are you?
Good, thank you.
Good.
Now, we have with us a special guest, Tim Miller, who's from Duke University Medical Center in North Carolina, is also, I think, the president-elect of the American Society of Enhanced Recovery. Is that right, Tim?
You are correct.
Tim, how's your meeting been going so far? I think you had a kicker meeting yesterday, didn't you?
Yeah, we had a one-day symposium which was put on by ASA in collaboration with the ASA. We had about 200 attendees, in fact about 210 I think, and we had to bring some extra chairs in.
Excellent.
A really good day, just discussing the latest evidence in enhanced recovery.
So I know we keep looping back on this, but from that meeting, do you get the impression that enhanced recovery is becoming standard practice in the USA?
I don't. I think that its uptake is variable, but I think that in some places it's standard practice, but in a lot of centres are still learning and wanting to implement enhanced recovery. So it's wide variety of implementation.
Do you think most people have bought into the idea now, though?
Yes, absolutely. I think people generally agree with the idea. We all know implementation is the challenging part.
Because we're running a poll, we're using the Slido technology, and we're running a poll here as part of our presence at Anaesthesiology 2018. If you go to slido.com, slido.com, and you put in TMT ASA 18, that's TMT for Top Med Talk, ASA for the ASA 18 for 2018, you'll find in there under polls where you practice is enhanced surgical recovery for elective colorectal surgery standard practice, or applied to selected patients, or in development, or not practiced as we don't believe it would be good for our patients, or not practiced as we haven't decided yet. And interestingly, 0% say not practiced because they haven't decided yet. So that would seem to align with your belief. There is a 9%, which we've had relatively few people have answered so far, the numbers are pushing up, say not practice as we don't believe it would be good for our patients. So we're still looking to find the people who are in that camp. We'd love them to swing by and to explain their rationale. We haven't managed to flush them out yet. But it would appear, as you say, is the majority. So 43% would appear to be standard practice, 35% applied to selected patients, and 13% in development are in. So a relatively limited poll at the moment it would appear that your hunch is right.
The interesting thing to me is the large number, 35%, that says applied to selected patients, because I don't really know what that means and why you would want to implement a program that applies to selected patients.
Well, we touched on that earlier, and I think that what we're getting out of the people who've been able to answer that question is that they're starting off cautiously in a sub-selected group of patients to build confidence. So in other words, it's not that unusual for people to say, let's do the first 10 or 20 in lower grade ASA right hemicolectomy, so we can work out to build confidence in the elements of the program. We know the benefit comes from applying it to everyone. Yeah. As we touched on earlier and on repeated episodes before, the sicker the patient, the more challenging they are, the greater the benefit. So you're long established doing this at Duke now. Everyone you do it for?
Do it for everyone, yeah. And we started off doing it for everyone because I think that's well, it depends how you want to implement, but I think there's definitely some argument that just implementing in everyone it makes it standard of care very quickly, as opposed to trying a select population. But it may be some centres have one surgeon who's very engaged and they start off with his patients, and other surgeons that are less engaged, for instance. So that could be an appropriate strategy, I agree.
Desiree, you've been involved in setting this up in a healthcare system and interviewed a lot of people about this. What do you think?
Well, I actually disagree that I think the standard of practice, and maybe they're reading the poll wrong, but I actually chose for my practice that we do still only apply to selected patients. We only have a couple of service lines. We only have, and we're not, we're hopefully doing it for all of them, but there are times that patients get selected out for whatever reason by the surgeon, so compliance is part of that. But I wouldn't say that it's, even though I feel like we were kind of ahead of the curve, we've been doing it for about 4 years now in enhanced recovery, or was where I practiced before. And I think they were doing a great job. It still wasn't standard practice. I don't think it's far.
So by service lines, you mean?
Like a colorectal patient versus an orthopedic patient,
right.
you know. Oh, elective colorectal surgery. Oh, God, it's too late in the day today, isn't it? Okay, for colorectal, ours is by surgeon, actually. We still have some surgeons that is not standard practice.
So, as I thought, yeah.
So why some surgeons?
Because we still struggle with the laggards, the people that are not wanting to come on board, and working with them still on, regularly to talk to them about data and things like that. But there's still people that are not completely bought into the whole process. They may be fine with some of the things that we do intraoperatively, but they don't participate in a full program.
But your results you presented are great in these enhanced recovery patients. Why wouldn't the other surgeons want their results to be as good?
There's always, 16% of people that are always going to, no matter what the data says, that you can't get them on board. So I think that's just been a struggle and a constant battle to kind of work with those.
So Mike, I know we've tortured this point, but where are you in Southampton on this?
So in theory, we do it on everyone, but actually, if I think about it practically, so we have some major sort of viscerectomy, so really, pelvic exenterations, that kind of thing, where actually, although we attempt to abide by the rules of enhanced recovery, it's not practical. They're often intubated overnight on the unit, so you can't follow the standard rhythm. But the principles underlying their care still, I think, reflect enhanced recovery principles. It's just the feeding on day one, getting them up and about, is probably not going to happen in some of those patients when they've had a 14-hour surgery.
Yeah, because your objective is to feed everyone as soon as possible, which for some patients is...
So we would like to see, oral nutrition, eating, drinking and mobilising on the first day after surgery, which we do in a lot of cases, but not universally.
So for this particular session, we're concentrating on enhanced recovery here, where we're transmitting from the Smith's Medical booth, on enhanced recovery through the whole pathway for this weekend. And we've got as far as concentrating on the fluid management component of it. And when we asked Henrik Kellett, when we did a special interview with him this morning, he reminded us that the original pathway only had 5, in his opinion, key elements to it. And in his opinion, one of the key elements is fluid management, and it's to give not too little and not too much. Now, Tim, you are an internationally recognised expert in this area, and you've spoken and written a lot about this. And quite commonly quoted is a risk-adapted matrix, which comes from an article by you, lead author by you. I saw it on a tweet yesterday, which says that the most complicated patients having the most complicated surgery should have advanced hemodynamic monitoring and a goal-directed approach. At the other end of the spectrum, there was a box that said zero balance. Now, when the article was written, we all thought that was the right approach to the less complicated patient, i.e. bring them to recovery area with a fluid balance of 0. Now, that's changed, hasn't it? Our thinking on that has changed.
It has. So the RELIEF study was published in the New England Journal of Medicine earlier this year, which was a multi-centre study by Paul Miles and his group, looking at restrictive versus liberal fluid management in major abdominal surgery. And they got nice separation between the two groups. The restricted group had approximately 2.5 litres of fluid in the operating room, and a very much a zero balance approach with overall weight gain, I think it was 0.3 kilos. So they pretty much stayed at their preoperative weight. Whereas the liberal group had about 3.5 litres of fluid. They were about 1.5 kilos positive, so 1 to 2 litres positive fluid balance at the end of the case. And there was a clear difference between the two groups with regards to acute kidney injury and the need for renal replacement therapy being greater in the restrictive group. And it's a nice story in a way, because the Bellamy Curve, the kind of U-shaped curve, has always suggested harm if you become too restrictive. The data, particularly from Mass General Hospital, observational data, 100,000 patients showed that the group that got the least fluid had a higher incidence of acute kidney injury. And now we have this large randomized controlled trial in the New England Journal, again saying that the group that were restrictive had a greater incidence of acute kidney injury. So I think the message is clear that we don't want to aim for zero fluid balance in the group that don't have advanced hemodynamic monitoring. We want to aim to be 1 to 2 litres positive. And I'm publishing an article at the moment with Paul Miles, and we've changed this risk-adapted matrix for that bottom left-hand group to aim for 1 to 2 litres positive.
And I presume therefore all the other quadrants as well. It's just because traditional goal-directed fluid therapy, one of the criticisms was you landed the patient about 1.5 litres positive. If you look at the literature overall, you never landed them 0. So I presume all quadrants are 1 to 2 litres positive.
Yeah, we've put it in every quadrant. So you do goal-directed therapy in those higher-risk patients, but aiming for 1 to 2 litres positive. So even though you're using advanced hemodynamic monitoring, there's some times when you're in the grey zone, shall I give a fluid bolus, shall I not? So it's useful to have an overall goal, and if you have that overall goal of aiming for 1 to 2 litres positive, it may be that you'll perhaps err on the side of giving a fluid bolus when you're in the grey zone, whereas perhaps a year or two ago you may have erred on the side of not giving it. So a subtle shift towards being slightly more liberal with fluids.
So I'm a resident in the PACU, and a patient comes back having had goal-directed fluid therapy using advanced hemodynamic monitoring, and the fluid balance is recorded as plus 1.5 litres. The stroke volume is optimal. Everything's looking perfect. Slap on the back. Hurrahs all round. Yep.
Yeah.
If they come back with minimal monitoring and the fluid balance is plus 500 mils, they probably needed more or should get more fluid. Is that basically it?
Yeah, obviously it's surgery dependent, but I think as a broad rule of thumb, yes.
So if in doubt, the one that's just half a litre positive, don't feel bad about dropping them an extra litre or so if they get a little bit hypotensive or tachy or oliguric, whatever it is. But when you get to the plus 2 litres, put the brakes on and increase the thinking or increase the monitoring.
Yeah, and liberal fluid management has got very bad press. I mean, from the studies that were done 10, 15 years ago with Brandstrup, etc., that liberal fluid management causes harm. And I agree that it does. But we have to remember that the harm signal in that really liberal fluid group was when you got 3 to 6 kilos heavier. You had 3 to 6 kilos positive fluid balance. So 1 to 2 seems to be about the sweet spot.
Mike?
Well, just to pick up on that, I think the restrictive group, I mean, it's always difficult to compare these papers exactly because the time periods over which the fluids are reported are a little bit different, but my reading of Brigitte Brandstrup's original paper is that the restrictive group in that study are comparable to the liberal group in Paul's study, and actually are also comparable to both groups in several of the minimally invasive cardiac output studies that were published at a similar time, where the separation was only about 500 mils. So they're kind of about 3.5 litres positive, not balanced, but 3.5 litres administered was common to many of those studies and would fit with the more liberal group in Paul's study.
I agree, and I think in Brandstrup's original study, as you say, the restrictive group were not that restrictive. It gave it the name, which was perhaps a bad name to use. And over the years, we've gradually given less and less fluid. And I think relief has just nudged us to make our fluid management.
And the terminology's been a curse.
I was just going to say that. It's the worst thing that could ever happen. I know you've told the story, and I have too. We've had people come up to us and say, I do a restrictive approach for my goal-directed therapy, and I gave 500 cc's of fluid for the entire, a large colorectal case or whatever it is. So
for those people who haven't subscribed to Top Med Talk yet, there's a back catalogue of 300 podcasts which are freely available to subscribers. Yeah. If you put in there relief, for example, you'll get a number of different interviews about the relief trial. And Paul Miles in particular was very, very generous. He teed us up for the results here at the ASA last year, has done repeated interviews about the granular details of that, which is a great contribution. And at the moment we're running across the ASA, we're running the top 10 podcasts, of which relief made it into the top 10.
Of course.
So, of course, which is great. Now, perioperative fluid management is more than just that bit in the operating room. So can I take you back, Tim, to the preoperative bit? Now, everyone seems to accept the no NPO after midnight. we'll talk about how often people apply that, but it's in all the guidelines. It's in the ASA guidelines.
Yeah.
So clears to 2 hours preoperatively. Some paediatric centres have gone to no NPO for clears. There seems to be some traction for that. And there's a lot talked about the carbohydrate drink. Now, I don't want to get into the type of carbohydrate drink. We've done that in detail elsewhere. I want to talk specifically about the diabetics, which are still stressing some people. So the carbohydrate drink, for some of us, it's a bottle of whatever it is the night before, a bottle the morning of. For others, it's just a bottle of the morning of. What do you do at Duke, and what do you do about the diabetics?
So we just give on the morning of. Yep. We don't do the night before. And we give it to everyone, with the exception of a brittle diabetic, a brittle type 1 diabetic, who are actually very, very rare. Other than that, diabetics will get the carbohydrate drink, and it does raise their sugars temporarily, as it does in everyone. Yeah. But one of the advantages of the carbohydrate drink is it reduces insulin resistance post-operatively, and I think that's clear, and that's as valuable, perhaps more valuable, in type 2 diabetics who already have some insulin resistance than any other patient. So I think it's very valuable to give the drink in type 2 diabetics, even though you will have a short-term sugar rise.
But the greatest benefit is thought to be in the diabetic. What about the previously unrecognised diabetic, which there's a large tranche of them, those who get quite a big sugar bump, and that tells you that actually they are pre-diabetic? What do you do about those? The unexpected on-the-day sugar bump where someone hasn't tracked their preoperative HbA1c, or does that never happen at Duke?
No, I mean, you will get some patients that put their sugar up and keep their sugar up. And folks say, well, should we be giving the drink because their sugar has stayed up? And I do agree, that's someone who's probably an undiagnosed diabetic. Those patients are probably, and we have some data now from Tracy Secchia, endocrinologist at Duke, at higher risk than people who are known to be diabetics and treated. So I think this puts those patients into a different category, and they should be started on an insulin infusion, and they probably should have an endocrinology consult post-operatively, because they are probably an undiagnosed diabetic needing treatment.
Because when I was younger, managing diabetics with intravenous glucose and insulin was de rigueur for major surgery. People seem to have shied away to it. Now they're a bit reluctant to start the insulin. Mike?
I think it's a really interesting challenge. My impression is there are two separate groups. So there's a large group of undiagnosed diabetics in whom an HbA1c is likely to be elevated. So if you look for it, you've got a priori evidence that they are diabetic, and they seem to do actually worse than the known diabetics, because I guess we don't focus the attention on them. And then there's another group who don't fit into that category but have a stress hyperglycemia response, who also, from the limited available data, look like they have worse outcomes than the previously known diabetics. And it feels like one of those areas that if we look a bit harder, we screen a bit earlier, we can get control working with the diabetologists and potentially make quite a big difference in not the known diabetics, but the unknown and the stress hyperglycemics.
But the key message is, if you're, as we keep talking about, is if you like to starve people to make them not look diabetic, that's the worst possible way of managing this situation. Desiree?
No, I mean, completely agree. And we, practically speaking, in the facility where I was working, struggled when we first started with the carb drinks, and we would draw hemoglobin A1Cs and do all the pre-op testing, but not really manage it necessarily. What you hear a lot about is that you have the levels, but then you don't really treat them. And so whenever we started the carb drinks, we really were dealing with a lot of hyperglycemia and canceling cases if their sugars were out of whack, and having the conversation with the surgeons, and then once we kind of understood what we were dealing with and started to do a little bit tighter control of glucose for those patients with their numbers that were fluctuating quite a bit, it didn't become a problem after that. And we learned to manage kind of, we would reduce for brittle diabetics, reduce the amount of carb drink that they ended up taking, or for some of our other patients, just treat it more aggressively. So.
And Tim, in the post-operative period, we've touched earlier on today about getting Foley catheters out quickly and being more relaxed about urine output. Are you still getting the IV down as quickly as possible? What are your criteria for getting the IV down post-op?
Yeah, we will frequently get the IV down in PACU as long as the patient is drinking and taking some oral intake. I do think that perhaps relief has just nudged us a little bit more to, in some patients, keeping the IV in for overnight on that first night. 'Cause again, they had the difference in their post-operative regimes.
Yeah.
And it may be that some patients are just not going to take enough oral intake, even if they're given a bottle of water. And there's maybe no real downside to just keeping a little bit of maintenance fluid in that IV overnight.
So perhaps relaxing towards what they had, about 1.5 mils per kilo per hour.
Yeah.
Overnight, and review it in the morning.
Yeah.
Because that takes out that slight anxiety of, I know we've been trying to, one of the reasons for getting the drip down in PACU is to show to people it was possible.
Yeah.
But there is a slight buffer in there to say, well, a couple of litres overnight. What we don't want is the drive-by shootings with saline for oliguria. That's the thing we're trying to stop.
Yeah.
So we're using the Slido technology not only for the poll, but also to submit some online questions. So if you go to slido.com and put in TMTASA 18, you've got a question here which, Tim, perhaps you can help us with. How important is the educational component to ERAS for patients and for the hospital team? So education, both for the patient and for the hospital team. How do you rank the educational bit of it?
I think it's probably number one. It's hugely important. And I think that, if you want patients to live the dream, to drink, eat, mobilise post-operatively, if you want them to empower them to be part of their own recovery, you need to educate them. And I think you need to do multiple different ways of educating the patients. We have someone speaks to them for around 20 minutes in the surgery clinic about enhanced recovery. They also get a booklet so that they can take home, which tells them all about enhanced recovery principles and how their post-operative course is going to go, including, of course, analgesia. And I think it's vital that we educate patients not to expect zero pain, to expect optimal analgesia. And if you've got a pain score of 3 or 4, but you can drink, you can eat, you can mobilise, that's a good way to be. There's so many things that the patients need to be aware of, so it's absolutely key. And I do think that a good education booklet that the patient can take home and review is hugely useful.
And how do you keep the staff educated, which is the other component of it they're asking about?
Well, I think an enhanced recovery... Sorry, Desiree. I think an enhanced recovery coordinator plays a key role because they can, keep educating staff in all aspects of care. Because there's so many staff that are involved in a patient's journey, from the preoperative clinic to the post-operative staff on the wards. And we're transitioning from one coordinator to another, and we've noticed that, as a lot of hospitals do, that when you don't have a coordinator, you get staff turnover, and keeping all those staff educated is a hard task. And
I was just going to actually say about the same. I mean, this is something that's frequently overlooked whenever you're starting a program. You just say, hey, we're going to start this new program. You lay out some protocols and pathways and expect people to accept that and do what the paper says. But it's so much more than that, and it's getting everybody on board. And when you first get going, I say this all the time, it's easy to get people excited about the program and seeing it work firsthand, but it's really difficult when you're trying to touch everybody that's involved with that and get them on board. And if you don't have somebody coordinating that, it's going to be very difficult, and you're not going to have a sustainable program.
Well, I think we've answered the next question, but just to make sure that we're clear on it, should every patient be scheduled for ERAS? And I think let's say every elective surgical patient first. Mike? Quick answer?
Yes.
Desiree?
Yep.
Tim?
I'd just like to add another comment.
I know that was coming.
Because I think there's a danger, and I was...
So when you cross the pond, do you get on a fence straight away, or does it take a while? Go on, Tim.
Listen to my point, and I was discussing this with Mike Grant from Johns Hopkins, and I think there's a danger that you label someone, you say, we're going to do ERAS in everyone, and you quickly spread to all these pathways, and you just give it the label of ERAS without doing all the implementation and the education.
Sure.
So that's the point I'm going to make, is places just say, oh yeah, we're doing ERAS here, we're doing ERAS there, but they're really not.
Right.
And you really need to walk the walk and go through due process rather than just saying, oh, we've got an ERAS pathway.
Okay, so let's take that question 2 sections then. Should every patient be scheduled for appropriately implemented, carefully engaged ERAS program, blah, blah, blah? Yep.
Yes.
Does every program need the detailed implementation, buy-in, education. Yes?
Yes.
Okay. Are there any patients not suitable for ERAS?
No.
Now, it has to be adapted to patient needs, doesn't it?
Exactly.
The mantra is procedure-specific pathways adapted to patient need. Yep.
And I always, people would say, I don't like protocols because you're just forcing this protocol on me. We should be doing personalised medicine. We should be doing individualised medicine. And I don't think the two are at odds at all. I think ERAS pathways are a framework for reducing unwanted variation. But wanted variation, needed variation, depending on individual patient needs, of course, can be a part of an enhanced recovery pathway.
We were discussing this in a meeting last week, is the protocols are there to benefit the majority that can stay on the path. The clever providers are there to try and work out when you need to deviate for the patient need. That's what you paid the big bucks for, isn't it? Is to work out who needs the deviation for subtle different components of it. So, what about other bits of ERAS? Where are you on cardiac, neuro, spines, peds? We're going to get asked about in a second. Tim, where at Duke? How far have you gone?
We're starting in some of those. Pediatrics is difficult, I think, because there's such a varied population in terms of the surgery type and the age of the children. They generally drink, eat and mobilise pretty well anyway.
You can't keep them down.
Exactly. But of course the principles of teamwork and a multidisciplinary collaboration of course apply to every service line.
Have you gone cardiac, or do you think you were there already?
We're in the process of starting cardiac.
Caesarean section?
Again, in the process of starting, and I think there's good evidence emerging that it's the right thing to do for caesarean section.
Emergency laparotomy, fractured neck of femur?
Fractured neck of femur, yes. Emergency laparotomy, no, currently.
Anything we haven't covered? I know there's a lot of... anything
Podiatry?
contraindicated?
No,
anything,
we started one.
Paddy, many, paddy, whatever it's called. Peddy, Manny. Is that
Manny Petty.
Manny Petty, there we go.
No.
You can do that for enhanced recovery as well. Anything contraindicated? No. Mike, emergency?
So there are obviously elements that you can't implement, some of the pre-op stuff, but I think the general principles stand.
Tim, specifically on the perioperative fluid management side of things, any other takeaways for us as we come to the close of this session?
I think we've covered it fairly well, unless there's anything specific that we were getting at. I do think that the hypotension is very topical that we haven't mentioned. I don't know, that's a big subject. I don't know if we want to get into that now, but I do think that our protocol has changed with the emerging evidence that a mean less than 65 can be associated with harm, particularly myocardial injury after non-cardiac surgery and AKI. So we very much fluid optimize first, and then if they're still hypotensive, we will add a vasopressor. And that's along the lines of the protocol that was in the Fedora study that you were part of.
So can I take you off at a tangent then before we close?
Of course.
Post-op troponins. Measuring post-operative troponins. Let me get at you first, Mike. You were involved in the MET study. That's a component of what's in the MET study. Now, we know that post-op troponin rises are relatively common, but then the question is, what do you do about it? Where do you stand on that spectrum at the moment?
So I think I have a particular view that's not at the centre of the spectrum, but I remain unconvinced. That what concerns me is that we measure troponins and we demonstrate adverse outcome down the road. There are many other markers that we could potentially measure and demonstrate adverse outcome down the road that might be linked to, for example, renal dysfunction or brain dysfunction. And I'm not entirely convinced that it's all about the heart, Doc. I think it may be about generalised inflammation, about an elevation of biomarkers that's more general. And until we know more, it's observational data. We do not have the causal link in most cases, and in some cases we've looked for it and not found it.
And troponins can be up in acute kidney injury.
Absolutely.
Troponins can be up in infection.
Yep.
Troponins can be up in other things.
So I've just, with our cardiologist, submitted an article to one of the intensive care journals around using troponin as a predictive biomarker for outcome, nothing to do with the heart in critical illness. And the cardiologists are convinced that that's a good idea. Forget the fact that it's a heart biomarker. It appears to have a much stronger relationship with how long you stay on intensive care.
But Tim, where do you stand?
Yeah, I agree with Mike.
Good move.
What are you going to do about
it? How are you going to react,
though? I think you've been pushing a few things around at Duke about what you might do next about it.
We've thought about it, particularly in the higher risk population, for instance, vascular surgery. But again, at the moment, we don't really know what it means. We don't really know what to do about it. So currently, we do not routinely measure troponin post-operatively. I think we're watching the literature. I agree with what Mike said. I think it is linked to inflammation. It's linked to outcomes, but we don't know specifically what to do about it with regards to the heart.
Because I'm still confused, because going to our surgical intensive care unit at work, you see people either there or readmitted with GI tract dysfunction, with infections, with lung problems, breathing problems, pneumonias, and you see them admitted with acute kidney injury. Those are the big ticket items. Very, very, very rarely see anyone with a heart attack. Now, the argument is that we're missing the heart attacks. But what am I missing there, Mike?
I'm with you, since we've been going through this journey over the last 18 months, 2 years, I've looked, because I did some surgical high care work, and I've looked harder for myocardial injury, and I'm still not finding it. Now, we're not doing screening for troponins, but anybody who might be suspicious, we're doing more serial ECGs, we're sending more troponins, and most of them are coming back normal.
So, Desiree, we've interviewed a lot of people about this. I remain completely confused.
So do I.
Good. Well, we'll have further, longer discussions about it. It's a really, really interesting area.
Yeah.
I'm still trying to work out whether it's an epiphenomenon. And people are telling me, no, it's a principal driver, but there's a disconnect here somewhere. I think this needs a lot of more concentrated thought and effort. Tim, any final words for us?
Yeah, I do think if you measure it, you're going to label a lot more people as having had myocardial injury, which is an interesting phenomenon in itself. So I just think it needs a lot of thought before we go down that line.
Is there any possibility that if you've got a slightly dodgy ticker, as we would say, and you're having to put up a significant fight to stop yourself developing major organ failure post-surgery, you might have to sacrifice a bit of myocardium to save the rest of your body? Because, I mean, when in the beta blocker trials, we decreased the number of myocardium events, but increased the coffin count was the trade-off. Is there another possibility we might be chasing the wrong rabbits down the wrong holes here?
I think it's a very significant risk. Really focusing on what appears to be an uncommon clinical outcome, as opposed to biochemical outcome, risks missing the main event in town, which is all the people who've got actually complications that are keeping them in hospital that are nothing to do with their heart.
Because another disconnect is we know that heart attack myocardial infarction is commonly written on death certificates. So there's this perception that it's what a lot of people are dying from. Whereas in trials where someone's writing down exactly what the patient died from, it's not as rare as rocking horse droppings, but it's close to it.
It was an uncommon event in the MET study, for example, where it was well looked for.
Does that translate, rocking horse droppings?
I was trying to figure that one out.
They're rare.
Yeah, I'm sure they are, yeah.
And I think just to elaborate on your point, I think that's very true, because it often is the final cause of death, but it's the sepsis and the multi-organ failure that gets them onto ICU
absolutely.
That really has caused the adverse outcome, with the final factor being, of course, the heart stopping, and that's what's going on the death certificate.
And that often gets written down on it. But if you're in a trial where they have to report exactly what the cause of death was and the adverse event, and it gets independently verified, it's very, very rare. There's a disconnect there somewhere.
And even in the IMPRESS trial, the amount of myocardial injury was very, very rare. I think it was one patient out of 300, was that right?
It was very low, yeah. And didn't really concur with the literature that's coming out of the United States.
No, which is very interesting.
Okay, well, we've lit the blue touch paper on that firecracker. We'll come back to it. Tim, thank you in particular for talking about perioperative fluid management. You're a very loyal friend and supporter of Top Med Talk. Thank you, Desiree, thank you, Mike. Thank you all for listening. Don't forget to subscribe, and if you do subscribe at Anaesthesiology 2018, not only do you get the full back catalogue of 300 or so Top Med Talks, you also have the opportunity to win this wonderful Marshall retro speaker here.
Right there.
There we go. There it is. That very retro, isn't it? A little beaut. Okay. You like that, Tim?
I can't see it very well yet.
Tim's going to be putting some fake emails in.
Its back looks lovely.
Go around and hang out.
We're going to plug it in and dance later.
Yeah. Mrs. Miller wants that, doesn't she?
She does.
Right. Cheers, everyone. We'll be back soon. Take care.
Thanks, Monty.
Top Med Talk.